All right. Welcome back to NeuroClarity, the podcast that sharpens your clinical thinking one fascinating case at a time. I am Onowori Victor, your host, and today's episode is a real neck turner, quite literally. I want you to picture this. A patient has transient weakness in the arm and leg. I am guessing you're thinking that's a stroke, right? But here's a twist. It only happens when he turns his head. Yeah, weird, right? We are diving into a rare but clinically essential condition called Vascular Eagle Syndrome. And this is where anatomy, hemodynamics, and diagnostic acumen all collide. If you're a medical student looking to understand the circle of Willis, a resident refining your differentials for transient ischemic attack, or you're a neurology who is craving the nerves, I want you to buckle up because this case has it all. This case is derived from the journal called Neurology, the Pierce and Oyster episode. And this particular issue was released on the 2nd of June 2025. That being said, let us meet our patient. We have a 57-year-old man with a history of hypertension who presents with a strange symptom. He has brief episodes of weakness in his left arm and leg, but they occur only when he turns his head to the right. The symptoms resolve the moment he returns his head to a neutral position. He also reports rare short-lived episodes of loss of consciousness, again, triggered by turning his head to the right. There is no pain, no facial numbness, no dysphagia, no diplopia, and no tinnitus. Classic vascular or neuralgic symptoms, right? No, not quite. Now, let's think like a neurologist. What's on your differential? Are you thinking a carotid transient ischemic attack? Well, maybe. Are you thinking seizures? That's less likely. Are you thinking of cervical spinal compression? Well, that could be. And are you thinking of Bow-Hunter syndrome? That's very possible. But we'll need imaging to narrow this down. Imaging was done and the initial non-contrast CT was normal. Then, a carotid CT angiography was done, and that is where things start to get interesting. In the neutral position, imaging showed an elongated styloid process on the right, which was almost kissing the internal carotid artery, but there were no dissection and no arteriosclerosis. So, the team thinks maybe we are missing something in motion, and with careful right-sided head rotation, a repeat CTA revealed impingement of the right internal carotid artery and an incomplete circle of Willis. Specifically, there was missing left A1 and right posterior communicating arteries. What does this translate to? Well, this means that there is very little collateral support if that right carotid flow drops. And to confirm the hemodynamics, they perform something we call a transcranial Doppler during head turning. The results are as follows. First, there was a 25% drop in flow velocity in the right MCA when the head is turned, and there was recovery when the head returns back to neutral position, and that hits the diagnosis: Vascular Eagle Syndrome, a rare, elegant, and now obvious diagnosis. The patient elected for a transcervical removal of the elongated styloid process, and it's measured about 4 centimeters. The surgery was uneventful, and post-operatively, there were no more episodes, no more weakness, and complete resolution. So, let's talk about Eagle syndrome. There are 3 flavors of Eagle syndrome, and they include 1, the classic pain variant, 2, the jugular variant, and 3, the vascular variant, which is our case today. The classic pain variant presents with orofacial pain, odynophagia, which is painful swallowing, and sometimes dysphagia, which is difficulty in swallowing. It is caused by neural compression of the glossopharyngeal, trigeminal, and or the caudate tympani. For the jugular variant, we have the styloid process compressing the internal jugular vein, and this can lead to thrombosis, headache, and even intracranial hypertension. For the vascular variant, we have compression of the carotid arteries, which could be internal or external, and this leads to dissection or transient hypoperfusion, especially with head rotation. It is rare but potentially devastating. What are our key diagnostic tools? Is CT with head rotation and a transcranial Doppler with provocative maneuvers. And of note, a styloid process that is more than 30 millimeters in length is considered elongated. Let's crack open a few oysters from this fascinating case. Eagle syndrome is rare but real, and you should always consider it in positional neurologic deficit, especially with transient symptoms. Our differential diagnosis includes 1. Hunter syndrome, where you have the compression located at the vertebral artery. 2. Benign paroxysmal positional vertigo. 3. Lehemith sign, which basically means pain when you flex your neck. And 4. Cervical cord or radicular compression. Not all elongated styloid processes are symptomatic, and about 4% of the general population have them, but symptoms are far less common. Patients who have an incomplete circle of Willis, like our patient, are at greatest risk, and you should note that only 12% of the population has a complete circle of Willis. In this case, the missing segment meant poor collateral flow, and this makes carotid compression very dangerous. Multidisciplinary approach is key, and you need involvement of the neurologist, the ENT, the radiologist, because they all have a part to play. Let's do a recap and let us reflect. What did you learn today? We saw a man with TIE symptoms, which occurs only when he turns his head. Imaging, Doppler plus clinical suspicion pointed to a diagnosis of vascular eagle syndrome. Anatomical anomalies like an elongated styloid process and an incomplete circle of Willis combine to create a rare but dangerous condition, and surgical intervention resolved the symptom entirely. So, next time you see someone with posterior or transient symptoms that don't quite fit the usual transient ischemic attack script, always remember eagle syndrome. It may just help you to save someone from a devastating stroke. And thanks for tuning in to NeuroClarity. If you found today's episode eye-opening, you can share it with a friend, colleague, or a trainee. Subscribe for more real cases, sharp insights, and neurologic clarity. You can also like and leave your comments and suggestion in the comment box below. Until next time, keep asking, keep learning, and never ignore a symptom that only happens when they turn their head. This is NeuroClarity, decoding the brain, one case at a time. Stay sharp, stay clear. Bye for now.